In global health, diseases rarely stem from a single, isolated cause. They operate within a complex, multidimensional network of interacting variables. To map this network, we are using a single case study, a cohort of diabetic patients monitored continuously over 12 months. This data frame holds our patient records. Each row is an individual. The columns track baseline traits like age, biological sex, and body mass index, alongside clinical measurements like HbA1c levels, circulating inflammatory biomarkers, and the exact number of months until a clinical complication occurs. When deciding how to analyze this data, personal preference plays no role. The rigorous mathematical framework is dictated entirely by the data structure. 3 factors determine the choice of algorithm: the research question, the outcome's mathematical metric, and the data's topology, whether looking at a single cross-sectional snapshot or longitudinal measurements. Selecting the correct mathematical method ensures the model accurately represents the cohort's behavior. Forcing an incompatible method onto the data creates statistical artifacts. Consider our first clinical question. How does a patient's BMI, age, socioeconomic status, and assigned treatment influence their final HbA1c levels? This 3D scatter plot visualizes multiple linear regression. This technique calculates a beta coefficient for each variable, telling us how much the outcome, HbA1c, changes for every 1 unit increase in a predictor, holding all other variables in the model constant. This technical output shows the foundational equation for our regression line. We have our intercept A, slope B, and the coefficient of determination, R squared. R squared quantifies the exact proportion of variance in HbA1c explained by our selected predictors. This model relies on rigid assumptions. The residuals must follow a normal distribution, the relationships must be linear, the variance of the errors must be constant, homoscedasticity, and the predictor variables must be independent of one another. If the clinical question changes to a binary outcome, such as whether the patient suffered a myocardial infarction, linear regression fails. We must deploy logistic regression. Logistic regression outputs an odds ratio. As shown in the source, odds are calculated as the probability of the event, p, divided by the probability of it not occurring, 1 minus p. The odds ratio compares these values between groups to measure association. A common analytical error is the assumption that an adjusted association from a regression model proves biological causality. A significant coefficient indicates a mathematical correlation when holding factors static. It does not guarantee that a clinical intervention targeting that variable will change the patient's outcome. Returning to our cohort, we face a structural challenge. Using multiple HbA1c measurements from the same patient over 12 months causes classical regression to collapse. Repeated measurements from a single individual violate the statistical assumption that all observations are completely independent. A patient's blood sugar at month 3 is inherently tied to their measurement at month 0. To analyze these individual trajectories, we must ask, how does HbA1c change over time, and do those paths differ between treatment A and treatment B? Mixed effects models solve this by splitting variance into 2 components: fixed effects, which measure average population behavior, and random effects, measuring variance introduced by individual patients. By assigning a random intercept, each patient starts at a unique baseline. By adding a random slope, each patient's disease evolves at its own pace. A frequent error is believing a mixed model automatically corrects for attrition bias. It only handles missing data effectively if data is missing at random. Mixed models account for individual patient variations to isolate the underlying population trend. Sometimes the analytical priority shifts from whether a complication happens to exactly when it happens. This requires analyzing for censoring. If a patient reaches the end of the study without experiencing the complication, or if they drop out, they are censored rather than deleted from the dataset. This Kaplan-Meier curve shows why. Censored patients contribute person time at risk to the analysis until they exit observation. Every time a patient experiences the complication, survival probability drops, creating a downward step. When a patient is censored, they're marked on the curve with a small vertical tick, while survival probability remains flat. The denominator of patients at risk shrinks for subsequent calculations. To adjust these survival curves for multiple covariates, like comparing treatments while adjusting for age, we use the Cox proportional hazards model. This produces a hazard ratio. It is a mistake to interpret the hazard ratio identically to relative risk. The hazard ratio represents the ratio of instantaneous risk rates and assumes these hazards remain proportional over the study period. Survival analysis respects the biological reality that time functions as an active variable of exposure. Metabolic biomarkers are often highly correlated. Including dozens of redundant inflammatory panels in a standard regression causes multicollinearity, which distorts the results. Principal component analysis, or PCA, handles this by compressing the variance of multiple variables into a few new uncorrelated axes. This reduction relies on loadings, which show the weight of each original variable, and scores, which represent the individual patient's value on the new mathematical axis. Standardizing the data is mandatory before running PCA. Without normalization, variables measured on larger numerical scales will falsely dominate the components. A common error in PCA is interpreting a mathematical component as a literal biological pathway. These components are abstractions designed to maximize variance and organize noise. They are not biological axioms. Unsupervised learning moves away from predicting outcomes. Instead, we search for underlying structures within the patient population. The clinical question becomes, can we find hidden phenotypes? We search for groups of patients who mathematically resemble each other across all measured variables. This dendrogram uses a distance function, such as Euclidean distance, to calculate similarity across multiple dimensions and link patients into clusters. Researchers use hierarchical clustering to explore natural branchings, or partitional methods like k-means clustering to force the data into a predefined number of groups. An algorithm's ability to separate patients does not mean the resulting clusters are biologically validated. A mathematical cluster is a hypothesis. It requires independent clinical validation before it can be defined as a real diagnostic phenotype. We can now consolidate these tools into a definitive decision framework. If the goal is predicting an isolated, continuous, or binary outcome, the path leads to multiple linear or logistic regression. Analyzing repeated patient measurements requires mixed effects models, while time-to-event outcomes with censoring require Kaplan-Meier and Cox proportional hazards. To simplify redundant variables, we turn to PCA. To group similar patient profiles, we deploy cluster analysis. Efficient analysis begins by defining 4 parameters: the nature of the outcome, the data type, the independence of observations, and whether the goal is to explain, track, reduce, or group. Apply these parameters to the scenarios on screen: blood pressure measured 5 times a year, the time to a first infarct, processing 8 inflammatory panels, and searching for an orphan phenotype. Assign the correct mathematical model to each. In global health, mathematics mirrors the study design. The statistical outputs are only as reliable as the precision of the initial question.